So, hello again. In the part 2 of the talk, we're going to focus more on the neuraxial anesthesia, and neuraxial really means spinal and epidural. So, some objective in this one, we're going to talk about, in this video, we're going to talk about some of the general aspect of the neuraxial technique. So, some anatomy of the central neural blockade, some significant effects that they cause specifically in cardiovascular system, and some observations post-operatively. So, to be able to place epidurals and spinals, you really need to understand the anatomy of the vertebral column, the ligaments, blood supply, the epidural space, spinal canal, and peripheral nerves. As you remember, we have 7 cervical, 12 thoracic, and 5 lumbar vertebrae, and 5 sacral vertebrae form the sacrum, and 4 coccygeal form the coccyx. The main function of the vertebral column are to maintain an erect posture so you can stand up straight and to really protect the spinal cord because it's a very sensitive organ. The vertebrae articulate at the inner vertebral joints and are connected to each other by lots of different ligaments. So the spinal canal is formed by the vertebral foramina, and its job is to provide support and protection to the spinal cord and its nerve roots. This is where the spinal anesthesia is injected. So as you can see, that's the spinal canal, that's where the spinal cord lives. Intervertebral foramina are where spinal nerves exit the spinal cord. These spinal nerves have motor, sensory, and quite often autonomic nerves. An epidural injection affects these nerves primarily. There are 3 layers of membranes around the spinal cord and its roots. The pia mater is close to the surface of the spinal cord and roots of the spinal nerves, and is the thinnest layer of a few cells thick. Pia mater is covered by a second layer called the arachnoid matter, and the space between these two is the subarachnoid space. It makes sense because it's under the subarachnoid, and under the subarachnoid space is the pia mater. And this is the space that's filled with cerebrospinal fluid, or CSF. And the blood vessels that go on out of the spinal cord traverse this place. And when we do a spinal injection, this is where we want the local anesthetic to go to. Superficial to the arachnoid is the thicker layer that is called the dura mater. And the area that the dura mater covers is called the subdural space. The space superficial to the dura mater is the epidural space. Ligamentum flavum is posterior to the epidural space. Pedicles and intervertebral foramina are lateral to it. And it's filled with fat, veins, lymphatics, and nerve roots, but there is no free fluid. So we call it epidural space, but it's really not a space. It's a potential space that if you inject fluid, this becomes a space. It expands and forms a space, but otherwise it's not a real space. The safest point of entry into the epidural space is below where the spinal cord ends because of possible spinal cord injury if we go too deep with our needle. So in adults, it means the lower border of L1, and in kids at the lower border of L3. In reality, we typically do spinal injection at L3 or 4, L3-4 inner space, or L4-5 inner space in most cases, because those are, especially L4-5 is the easiest place to do it. And when you put your hands on the iliac crest on a patient, the connection between its superior aspect cross either the spinous process of L4 or the L4-L5 space. So where you feel the iliac crest, at that level if you do your injection for spinal, you're safe. Now, some absolute contraindication to neuraxial anesthesia are, of course, patient refusal, infection at the site of injection, hypovolemia, indeterminate neurologic disease, severe coagulopathy, and increased intracranial pressure. But there are relative contraindications too, like sepsis, the uncooperative patient, severe anatomic abnormalities, etc. Nowadays, so many of our patients are on anticoagulants and antiplatelets, and these definitely increase the risk of hematoma formation in regional techniques. And this can lead to some really, really bad nerve damage and consequences. There are some specific recommendations from ASRA, that is the American Society of Regional Anesthesia, in the timing of needle insertion, catheter removal, etc., in regards to each anticoagulant. And the easiest way to get the most updated information is to use their app that Azra makes. It's called Coags. And if you download it, you can get the most updated information in terms of, when it's safe to do a spinal anesthesia or epidural, when it's safe to remove an epidural catheter, etc. So, for example, when somebody's on aspirin and NSAIDs, there's really no contraindications to doing these techniques if those are the only things they're taking. If somebody's taking clopidogrel or Plavix, it has to be held 7 days for safe epidural placement. If somebody's on warfarin or Coumadin, the INR should be less than 1.5 so that we can do the procedure safely. And again, there's always exception to the rule, but these are true for the most part. There are so many side effects and complications associated with neuraxial techniques, like anything we do in the hospital. Of course, inadequate analgesia is one of the most common ones. It can be because of incomplete coverage of the surgical area, septated epidural space. There could be some congenital septae in there. Migration of the catheter, it can always happen. We can fix it though. We can reposition the catheter, increase the concentration or rate of the infusion that we're running, or by adding other drugs to the solution like opioids, alpha agonists like clonidine, and they all work in epidural space too. We can even use systemic agents like NSAIDs, acetaminophen, or opioids to help with the breakthrough pain, even if they're not perfect. Now, the cardiovascular effects can be significant. We can get an intense cardiac sympathetic blockade that can cause bradycardia and hypotension when we block the autonomic and there's venous pooling. We should treat bradycardia with anticholinergics like atropine or glycopyrrolate, and hypotension with fluids and vasopressors as needed. Pruritus or itching occurs in about 8.5% of patients. And this is really not from the local anesthetic that we inject. It's actually from activation of the opioid receptors in the spinal cord, and is often seen when opioids are used in epidural or spinal space. And it's best treated with opioid antagonists like naloxone. Benadryl doesn't help this, and that's the most common agent used in the hospital setting. And interestingly, ondansetron has been shown to be effective in treating this, but the best one is opioid antagonist naloxone. Nausea and vomiting can definitely happen, and it's likely from opioids, or if the patient are hypotensive from lack of perfusion to the gut, they can get nauseous. Urinary retention is more common in men with receiving opioids and inhibition of the parasympathetic nervous system of the bladder. These are one of the last autonomic fibers to regain their functions when the local anesthetic is wearing off. And significant urinary retention can occur in the first day or two and often resolve pretty much spontaneously. But these patients will need to be catheterized with a Foley catheter to empty their bladder, otherwise they get a sympathetic surge from full bladder. Now, respiratory depression can occur because of the absorption of opioids into circulation or CSF. So regular assessment of the level of sedation, the character of respiration, oxygen saturation are absolutely essential. And we need to adjust our infusion rates through the epidural space, or even run the patients on naloxone infusions. Every once in a while that happens. Another common one is post-dural puncture headache, and it's also known as a spinal headache, and it's from a leak in the CSF through the dura. And signs and symptoms of leakage, which is usually seen at least 12 hours after the dural puncture, but usually 24 to 48 hours after the procedure. And their signs include frontal or occipital headache, tinnitus, double vision, nausea, and photophobia. But the most characteristic feature of post-dural puncture headache is the position dependence of this headache. So typically, the pain is extremely severe when the patients are standing or sitting, and quite tolerable when they're laying down. And mild cases respond to NSAIDs, caffeines, or gabapentin, hydration with IV or oral fluids. But more severe headaches may require what is called an epidural blood patch. And it is a procedure very similar to epidural, where we inject 10 to 20 ml of the patient's own blood into the epidural space to basically coagulate and stop the leak from the CSF. And it's really a hematostatic plug, closing the tear and preventing more CSF leakage. And this technique is usually very quick to work, and it's effective in at least 90% of cases. Now, epidural abscess and hematoma are very rare, but they have, as you can imagine, quite devastating consequences if not managed appropriately. Epidural hematoma is likely to occur on removal of the epidural catheter as insertion. So you got to think about anticoagulants before and after the epidural the entire time. Abscess formation should be on top of your diagnosis with when patients are pyrexic, they have fever, localized pain, or increasing sensory and motor dysfunction. These are the patients that if I suspect it, I order a stat MRI immediately. I call the radiologist on call and stay with the patient. As soon as the scan is done, I go to the radiologist suite and see the images with the radiologist. If it's an abscess, I call the neurosurgeon on call myself and get the patient to the OR before the neurosurgeon even changes and comes out of the locker room. Because if surgical intervention is delayed more than 12 hours after the first neurologic sign, the odds of permanent neurologic injury goes up significantly. And often the time that I hear about it, it's been more than a few hours since the patient started having symptoms. So we're on a clock.